Heart attacks, medically called myocardial infarctions, occur when blood flow to a portion of the heart muscle is blocked, usually by a blood clot forming on a ruptured plaque inside a coronary artery, causing the heart muscle cells to be starved of oxygen and die. But what is less widely understood is that in women, the entire presentation, underlying mechanisms, and outcomes can differ significantly from men. And these differences are not minor. They can mean the difference between timely treatment and a fatal delay. Anatomically, men and women have similar large coronary arteries, but women tend to have smaller caliber vessels and are more prone to microvascular dysfunction, where the tiny branches of the coronary arteries fail to dilate or supply adequate blood flow despite the absence of major blockages on angiograms, which means their heart attacks can be caused by widespread, subtle narrowing instead of a single large clot, leading to more diffuse, vague pain that is harder to pinpoint. Hormonally, estrogen protects premenopausal women by maintaining flexible arteries, healthy cholesterol balance, and reduced plaque buildup. But this protective effect drops sharply after menopause, accelerating atherosclerosis and increasing clotting risk, and conditions like diabetes and high blood pressure, both of which damage the vessel lining, cancel out estrogen's benefits even earlier in life, symptom-wise, while the stereotypical Hollywood heart attack of crushing central chest pain radiating down the left arm happens in both sexes. Women often experience atypical or silent symptoms such as shortness of breath, profound fatigue, dizziness, fainting, cold sweats, nausea, vomiting, indigestion like discomfort or pressure in areas not commonly linked to the heart, like the upper back, jaw, neck, shoulder, or even between the shoulder blades, sometimes without any chest pain at all, which makes them more likely to misinterpret the warning signs as acid reflux, flu, anxiety, or stress, and studies show women are more likely to delay calling emergency services for this reason. In addition to atherosclerotic plaque rupture, women face higher rates of conditions like spontaneous coronary artery dissection, SCAD, in which the wall of a coronary artery tears and creates a false channel for blood, restricting flow and causing heart muscle damage, often occurring in younger women without traditional risk factors, and sometimes linked to pregnancy or postpartum hormonal changes. Another condition more common in women is Takotsubo cardiomyopathy, also called stress-induced or broken heart syndrome, where extreme emotional or physical stress triggers a surge of stress hormones that temporarily stun the heart muscle, mimicking a heart attack with similar symptoms and abnormal ECG results, but without blocked arteries. Autoimmune diseases such as lupus and rheumatoid arthritis, which are more prevalent in women, also increase inflammation in the arteries, contributing to premature heart disease and depression. Another risk factor for both onset and poor recovery affects women nearly twice as often as men. Furthermore, social and cultural factors play a role. Women may prioritize family responsibilities over their own health, hesitate to seek urgent care, or face unconscious bias from healthcare providers who may underestimate cardiovascular risk in female patients, leading to fewer referrals for cardiac testing and delayed interventions. Diagnostic challenges also arise because women's ECG changes can be subtler, and they may have normal results on standard angiography despite severe symptoms if the problem lies in the microvasculature, requiring advanced imaging or specialized testing like coronary flow reserve measurements. Prevention strategies are therefore both similar and specific. Controlling major risk factors such as high blood pressure, diabetes, and high cholesterol, quitting smoking, maintaining a healthy weight, engaging in regular aerobic and strength exercise, managing stress, eating a diet rich in vegetables, fruits, whole grains, legumes, lean protein, and healthy fats, and limiting alcohol intake are universally important, but women should also be particularly vigilant about changes after menopause, monitor for autoimmune flares, and discuss pregnancy-related complications like gestational diabetes or preeclampsia with their doctor, as these are now recognized as red flags for future heart disease. Awareness campaigns stress that any unusual, persistent discomfort in the upper body, unexplained shortness of breath, sudden weakness, or severe fatigue, especially if accompanied by lightheadedness, sweating, or nausea, should be treated as a possible heart attack until proven otherwise, and immediate action by calling emergency services rather than self-driving to the hospital is crucial. Medically, The difference in heart attack presentation between men and women is not about one gender's heart being weaker or stronger. It is about how biological, hormonal, vascular, and even psychosocial factors intersect to alter disease patterns, symptom perception, and treatment responses, and ignoring these differences can cost lives. Ongoing research into sex-specific cardiac care aims to improve diagnostic criteria, treatment protocols, and prevention strategies tailored for women, because recognizing that different does not mean less serious is the foundation of better outcomes and a future where women's heart health is given the same urgency, specificity, and respect as men's.